So there's a couple housekeeping elements. There are seats in the front. There's about 10 seats I can see over here. So those of you who are in the back, please feel free to make your way to the front. We're now setting up for a panel, and I'm delighted to invite Alison Paprica, VP Health Strategy and Partnership at Vector Institute, to come up and chair the panel. She'll be introducing the members of the panel, and we probably should just have the members of the panel come up and take their seat. So Alison is Vice President of Health Strategy and Partnerships at Vector Institute. She's been a great partner in putting today together. She joined Vector after more than 20 years of management experience in the government and private sector. In particularly, she's all about data. She worked and led strategic partnerships at the Institute for Clinical and Evaluative Sciences, which is where Ontario aggregates a rich set of data from across that single insurer. And she's worked to expand the partnership and really let this data start to move. So I'm not going to take much more time to introduce Alison to keep us on schedule, but her bio is available online. And Alison.
Thank you so much, David. We're very pleased at Vector to be part of this event, right from the steering committee to being here today. And I'm going to say hello to Richard Resnick, who we've never met in person. So another added bonus of this symposium. As David mentioned, my bio is online, and I won't say anything more about that. But I did just want to mention, for folks who aren't aware, a little bit about the Vector Institute. A little bit over a year and a half ago, Vector was founded with empty space concrete and a commitment for funding, which ultimately translated into funds from the provincial government, the federal government, and quite uniquely, a number of industry sponsors. So we're a hybrid research institute. Okay. And in just over a year and a half, we've gone from those bare concrete walls to a community of now over 200 researchers, which at its heart has world-class machine learning research scientists, some of whom, like Marja Gassimi, you're going to hear from later today. Our topic for today, maybe we'll switch to the slides, is social license and the use of health data for AI. And we thought we'd just say a little bit about social license. It's not a new term. It's been around since the 90s, the late 90s. And it has its origin actually in natural resources and areas like mining. And the basic idea being that there's this thing called social license. It's not a legal or formal agreement. It's more something that's ongoing with the communities that you interact with, where an organization, it could be private sector, it could be public sector, essentially has an understanding with the relevant stakeholders to undertake a certain activity. And the interesting thing about social license is the organizations that have it may not even know that they have it until they step outside of it, at which point, I love this quote, it becomes obvious to all, incurring both human and economic costs that can sometimes be irreparable. So it's been around for a long time, but more recently, we've started to use it a lot when it comes to health data. And I think it fits really well. And so to our knowledge, I did just a Google Scholar search. If you look up health data and social license, you'll find publications mostly over the last few years. But I've never actually seen it applied to health AI. And I think given Kevin Smith's great open remarks about the importance of trust and alignment with public values, my hope is that it's a term that takes off after today, because I do think it's highly relevant. One way of expressing it is social license distinguishes between those things that maybe we should or ought to do from those things that we can do that are technically possible. So I'll move to the next slide. Okay. So when I first started learning about social license, I sort of thought, well, there's this set of activities represented by this circle of things that are legally allowed. And social license might look something like this. It might be a subset of the activities that are legally allowed. But as I came to discuss it more, in particular with international experts in the UK, I found out that's actually not the case. There are things that are not legally allowed, which the public actually wants us to do. So to give a very concrete example, at the Institute for Clinical Evaluative Sciences, ICES, they produce reports which they provide to family physicians that might say, for example, 5% of your patients are at high risk because they have elevated blood glucose levels. But they can't say to the physicians, and these are the 5 patients. That's not legally allowed at this time. The other thing we've learned is that social license varies by jurisdiction. So for example, in Denmark, where there's hundreds of years of history of working with large public data sets, a researcher can go directly to a member of the public and say, would you like to be part of this study? But in Scotland, they make a point of it being someone within the circle of care who approaches the patient because it would bother people to think that researchers had access to their data. And of course, social license can change over time in response to things that happen outside of the health sector in our case. Now, I wanted to, before moving to introducing the first panelist and really getting into the discussion, I wanted to say that even as I'm saying this, I know, many of us are in a space where we're trying to introduce something new into environments that are not necessarily fit for purpose. We have policies, we have data infrastructure, we have rules that make it very hard for us to get these new initiatives like Health AI off the ground. And it's possible that as you hear me talk about social license, it sort of sounds like, oh no, here's one more thing in this already complex environment where we're trying to get something off the ground. What I wanted to emphasize is it's true it might be something new, but I'm going to argue that it's very worthwhile. Because if it turns out that you're right on the edge of that social license circle, it's going to be far better for you to find out about that at the ideation or planning stage than to get deep into it and find out that you're doing something that stakeholders don't agree with, be it the public, your clinician colleagues, the IT folks who say that's just not possible. You want to know where you are. Because there's lots of circles, right? There's lots of players who are saying, we think this is a good idea when it comes to health AI. And that section in the middle, if we focus our effort on that right from the start, if we know we're doing something that we're pretty sure is within social license, and everybody thinks it's a good idea. The computer scientists think it's a good idea, the clinician scientists think it's a good idea, the executive leadership thinks it's a good idea, the public thinks it's a good idea, that's the sweet spot. That's the kind of initiative that's going to provide value in itself and fuel future applications. So this lens of taking social license into consideration right from the start, it's sort of a form of team science, which again, Kevin made reference to in his opening remarks. Health AI is team science, and that's the spirit that we're bringing this discussion here to you today. So what I'm going to do is I think I'll introduce our panelists in the order that you see their bios. I'll do them one at a time, and each person's going to speak for about 5 to 7 minutes about their views on social license, in some cases bringing forward some very particular examples. Then we're going to have some fun. We've got some live polls, and we're going to force you to say, do you think this is within social license or not? And then there'll be some time for dialogue and Q&A with the panelists, both about what they'd presented as their own thoughts in the polls that we all respond to. So with that, I'll introduce, to start, our first panelist, Jennifer Gibson. So Dr. Jennifer Gibson is the Sun Life Financial Chair in Bioethics and the Director of the University of Toronto Joint Centre for Bioethics. She does a lot of work with the World Health Organization, and currently she's leading a new program of research, which I'm very pleased to be involved in, which is called Ethics and AI for Good Health. And we'll start with Jennifer's sort of 5 to 7 minute reflections on social license, and then I'll introduce the next panelist.
Good morning, everybody. So really I've been looking forward to this particular panel precisely because I think this is a real opportunity for all of us to really think about social license in a way, but also to drive research in this area because we are looking at some really fairly big knowledge gaps right now about for what activities related to data and AI do we have social license, particularly in Canada. So I'd like to float 2 different scenarios with you and use those to explore what I think some of the heart of the matter might be, some things that we might be able to bring into today's conversation. So let us imagine a situation like the following. Let's suppose for public health purposes, a government or a health institution wants to use their data that they have in order to track infectious disease. We're in flu season. You ask a member of the public, is this flu season? Yes, they can't but see billboards everywhere. And if we were able to track and anticipate better where there might be pockets of flu, where somebody might get sick, who the vulnerable populations were, I think we would have social license amongst most of us in the room and out in the general public, that would be good use of data. that we could anticipate, identify the vulnerable, and respond. And then similarly, to be thinking about sustainability within our system. We know that we need to make choices, but what if we could leverage the data that we had, applied some novel analytics to be able to inform better or wiser decisions for the use of our resources? For that, I do believe we would also receive a great deal of social support and public support. Now, by contrast that, if you will, to a situation where, again, collecting data for a collective purpose, that purpose happens to be for the purpose of tailoring group health insurance products. So a health insurance company developing products based on massive data sets that they have, and we might ask the question, would that have the same degree of social license that we might have expected in the public health purposes case? And I'm going to suggest that whereas there would be social license in the case of the public health purposes, I think we would find that there would be less in the case of the creation of insurance products. And let me just tease out why this might be the case. So at the heart of the matter, and it sounds like trust has already come up this morning, I think the heart of the matter is trust. And the problem we've got right now is we don't have a lot of evidence about what Canadians think about AI or its use, or what they would in fact attribute social license to. That's a knowledge gap that we have to appreciate right from the get-go. So in order to try to pool some insight from this, it turns out in the last couple of years, there have been a number of public opinion polls around trust, polling Canadians. So I looked at some of those polls to see if I might be able to draw out some strands that would help us to understand what may be on the minds of Canadians. One interesting observation was in a recent poll that was done by Environics, now called Proof, only 25% of Canadians trust AI companies. Now, that maybe isn't surprising. AI is pretty new. Most of us don't understand what it is or what it could do, and so it may be simply due to lack of familiarity with these technologies. So then, who do Canadians trust? Overarching across these two surveys, they trust not-for-profit organizations. And if we drill down further, they actually trust hospitals in the healthcare sector and universities. By around over 60% of respondents trusted those types of organizations. And toward the bottom, I bet it won't be a surprise, health and life insurance companies at the bottom around 28%. Now, those are interesting little factoids in themselves, but I think it's how when we put those together, we start to see potential narrative emerging around trust and those two scenarios I started with. Low trust in AI, which is a phenomenon that seems to be around the 25% low trust in that area at this stage, plus low trust in life insurance companies may contribute towards lower social license for the use of certain types of data that might be housed by insurance companies. Correspondingly, low trust in AI together with high trust in the health sector strikes me as an opportunity where there may be an opportunity for social license to work together in partnership from the public with the health sector to leverage those opportunities. But let's take a step further to ask the question, why? What explains this difference? I mean, the surveys are not saying that life insurance companies ought not to be trusted. They are perceived not to be as trustworthy as the healthcare sector. So let me suggest there may be three reasons. First, maybe the purposes for which the data will be used. The second is whose interests will be served. And the third is whose goals or what goals and values are driving the organization's actions and decisions. In both examples, we're talking about a scenario where we're analyzing data in aggregate to generate insight to serve some sort of collective good, but they're materially different in those three respects. Purpose, public may perceive the purpose of improving health more favorably than creating consumer products with the same sorts of data. They might also look at the public health purposes as particularly valuable precisely because they serve individual and population health interests, the public and its members, whereas the key beneficiaries of these insurance products would be the company's shareholders and their employees, or their clients. So organizations like hospitals, like universities, who might purchase those products. And then third, there may be differences in the values and the goals that may be operating here. On the one hand, public health purposes together with the focusing on the interests of the public might have as its embedded values doing good, addressing equity concerns, sustaining communities, and perhaps even solidarity, as compared to generating financial interest, keeping promises with shareholders, or maintaining a market share. Of course, some of this ultimately turns on perception, and so rather than reality. But perception, I think, matters when it comes to social license, because it's the combination of perception and experience that creates conditions for trust. Trust is earned, and we look for evidence to the contrary to lose trust in those institutions and individuals we care about. So as we talk about social license this morning, just to regroup around my key messages, it's about trust, it's about purposes for which the data is used, it's whose interests are served, and the values that animate that activity.
Thanks, Jennifer. And it's interesting, I can't help myself as we transition to the next speaker to note that, our laws about privacy, for example, are absolutely silent on private versus public sector. So that's a great example of where we have something coming through the trust surveys that isn't represented in the law. Our next speaker is Dr. Heather Ross, who I assume many of you from UHN in particular know very well. She's a cardiologist at the Peter Munk Cardiac Center, professor of medicine at the U of T, director of the cardiac transplant program at Toronto General Hospital, director of the Ted Rogers Center of Excellence in Heart Function, site lead for the Ted Rogers Center for Heart Research, and she currently holds the Loretta A. Rogers Chair in Heart Function. Not only that, but Heather is an MD with a master's degree in bioethics from the University of Toronto. She tells me she thinks she was in the second class ever. That was it. In addition to publishing over 250 articles and winning numerous teacher awards, she was named by Canadian Geographic as one of the top 100 modern-day explorers, a unique biography, a unique person who's going to share her unique perspectives now on social license.
Thank you. I think this is an area of exploration, and I guess I'd start by saying that the complexity of medicine has far exceeded the capacity of the human mind. So I think if we use that as a starting point for where we are, that's a nice way to frame the challenge. So to me, an example that would fall within social license is the use of broad, anonymized echocardiographic data in order to train a fully automated echocardiogram interpretation tool that improves diagnostic accuracy, a self-driving echo lab, if you will. So why do I think that? Well, there's incredible variability in care. And you're the echocardiographic doc, you're on call, it's Friday afternoon, you were up 3 times through the night, you have 4 people in the emergency room, you've got 30 echoes that you have to read, they have to be read that day, and that type of fatigue that happens and the pressure of all those different challenges that are on you on a Friday afternoon means that some echoes may be read maybe a little faster than others, and you may not give true due attention to everything. So this is a form of augmented AI where we use, and this has been shown and done, that you can use training sets on echo to actually teach a automated system to recognize the contours of the echo, to calculate simple things like ejection fraction, volumes in echo, and in actual fact, predict certain conditions. So a very recent paper looking at trastuzumab therapy, chemotherapy, and the potential that it has caused cardiomyopathy in terms of looking at echoes. So going past just looking at standardized values on echoes, but actually into disease characterization. This isn't to replace the echocardiographer. This is to actually provide the information and help reduce this incredible variability that we know that can happen and sort of say, hey, did you see this and did you see this? And try to improve accuracy. And I think most individuals who have provided echo data in an echo lab would be comfortable with their data being used to train that type of system. And I think critically, this is a form of augmented AI. I think we get very concerned around automatic, where we have no input and the doc maybe doesn't come in and recheck and make sure about the accuracy. But I think most patients and individuals would be comfortable with that type of system. I think stepping outside of that is the release or sale of so-called anonymized complete health record imaging and specialized data sets to pharma to enable them, for example, to determine the market for a new drug. And although these data sets are theoretically anonymized, the real question is what social good would this serve? What public good would this serve? How will this help when we look at what we really think AI can do in healthcare around improving precision medicine, diagnostic accuracy, reducing errors, and discovery medicine? How will this enable those goals of AI in medicine? And how can we be absolutely certain that we cannot re-identify? And I'm reminded of the recent article out of Australia where they took a set of apparently de-identified data, and by using common pieces of information that were publicly available, they were able to start re-identifying that so-called anonymized data. And so the challenge there is these independent aims of protecting individual privacy and the publication of these detailed records to enable further research. So I think that example where we are selling so-called anonymized data that maybe isn't as anonymized as we'd like, that doesn't clearly promote the public good, or I think the true goals of AI in healthcare would fall outside of social license.
Our next speaker, whom I came to know last night over dinner in very enjoyable circumstances, is Marilyn Myers, and she is a patient partner from UHN. And I think she made such an impression on David Jaffrey, as I understand it, through her outspoken contributions at numerous meetings, that when we identified the strong need to have a patient as part of the panel, Marilyn was immediately contacted. She is a retired senior marketing professional with a strong career with IBM Canada and IBM Global Marketing Organization. Upon retirement, she established her own marketing consulting business, and following that now is an active member of the UHN Partner Program, Patient Partner Program. Her experience, as many folks who come to be involved, it comes from a personal 10-year journey as a patient caregiver within the UHN realm of healthcare facilities, and she brings that perspective, that important perspective, to this discussion and the work she does with IBM. She continues to be a results-focused team member with strong expertise in reaching the right target audiences, coaching teams and individuals to achieve results. We're very pleased to have Marilyn as part of our panel.
Okay, have I pushed the on button on? So far, so good. Good morning, everybody. Delighted to be here, and I must say I think from what I've heard so far, the general public in the older adult category. So happy to be sitting up here with all of you and energized with what's going on. I wandered outside, I saw the posters, and I am a glass half full type of individual. And I am absolutely excited and energized when I see all this work that's going on. And yes, I know there's challenges. And when I was given this topic maybe 2 or 3 weeks ago, and I kind of gulped and went, boy, I don't even know what this is about. And I started Googling it and whatever. I thought, okay, stop that. I went out and talked to 30 of my closest friends, colleagues who are not in the industry, and said, okay, talk to me a little bit. What is AI? What do you think it is? What's social license? What do you think it is? And I got all kinds of interesting answers. I got some appalling, keep it away. But for the most part, everybody was much like myself, which is bring it on. We need change. We need new things. We need the use of the technology and the data that's going to help us work together and help with diagnoses and help with treatments and do all those things so that our people in the medical profession can do what they do best, which is deal with the people, because there's work out there that's helping them do a lot of that data work so that they can deal with us and talk to us and help us. So I thought that was very positive, and I was pleased to hear that from most of my friends and colleagues. The other thing that I think on the social license and the positive is I see it as a real ability for people to be able to collaborate and come together and work more as teams, rather than so much of what I think I see now is done on an individual, pillared basis. And I can see this as allowing a lot more of sharing of knowledge and working together and understanding what people all over are doing, which to me is a yes, and again, extremely positive. I was asked to comment a little bit on the no part of social license, and as the first speaker said, what came out for myself and the people I talked to, fortunately or unfortunately, were insurance companies. Nobody wants their data or their information as much as they have already shared now with insurance companies, shared more, and to have them have the ability to access our information. Now, a lot of that came with the older adult category because we are now able to do a lot of traveling. And the thing that boosts up your travel costs is your insurance to be able to travel. And the feeling was the more data these people can get their hands on, we can maybe afford the trip, but we can't afford the 4 weeks of health coverage just in case something happens. So hopefully with all the discussion today and whatnot, there will be ways of how do we manage the access to the information and who out there is really going to be able to get into all of this artificial intelligence and the machine learning and get everything that can be used to our benefit rather than our detriment. And the next thing I was asked to talk a little bit about, and I sort of put this in my own way, the way I always have put any kind of project or any activity together, and when I spend a lot of time here within UHN and a lot of the hospitals going through the emergency rooms and the clinics and all of those kinds of things, you see a lot and you learn a lot. But everything to me can come down to some basic questions. Who is it we're targeting? Who is it we're trying to help? In this case, who is it that's going to be managing and accessing all of this information? How are they going to be able to access it? Is it going to be an easy process? How is it going to be distributed? Who is going to be able to decide what is used in the data? And a lot of those points came up as I talked to my colleagues and friends. And those W's and the H go way back from when I first started out in the marketing business, was the old who, what, where, when, and how. And I still see that being applied constantly. And it was applied this morning in the different speakers we've heard. So I just think that's something that's important to keep in mind and make things clear. People don't understand AI. They've read a headline in the newspaper, or they've read something on their iPad, but nobody really understands what it is and where it is. And one of my friends said to me, and please don't tell me it's in the cloud. I still haven't figured out where the cloud is and who turns it on and who pulls all the information out of it. And you kind of go, oh, okay, that's interesting. So what's next? How will social license be defined and decided? And that, from what, again, I've learned this morning, I think it's going to be a lot of different things, and it's something that likely can be applied in different scenarios. So what is social license in one area may not be the same thing in another area. So I see our guidelines as having to have some flexibility and not being managed by one group of people saying, thou shalt do it this way. No, no, no. We're in an environment where there's give and there's take, and everything has to be soft like a ball of Play-Doh, and you adapt that to your different scenarios. So that was almost my last comment. The other thing that excited me about this topic and the social license is so much of what I do now, health-related, I already have in places. So I'm personally connected with sports medicine in the Cleveland Clinic. They have MedChart. So I've accessed MedChart, brought it into my phone. All my medical data I've now put into MedChart. I have it in my Apple Wallet. I have it in my health app. I have it at the pharmacy. I have it with my insurance company. I have so much information now out there in different places. So one of the things that bubbles through my brain, listening to all of this, is how does all of my information get brought in to where it can be of value? Because now it's in half a dozen places that I can just pick up my phone, punch a button, and there it is. But that doesn't mean it's out somewhere where some of these experts in this room can do something with it of value. So that's something that's bubbling around in my brain. Anyway, I'm sorry, I've actually gone over my time. Thank you.
Thank you so much, Marilyn. Our last speaker on the panel is James Bateman. He is the CEO and co-founder of MedChart. He's here in that role. But he has a very interesting history, as we learned over dinner. He started his work founding a family business with his father as a specialist in carpentry. And he's the kind of individual that would go from that to saying, you know, I think I'd like to go to engineering science major in physics at the University of Toronto, publishing in some of the top journals in the field by the time he exited that. In early 2016, he got his degree in engineering. He was awarded an NSERC scholarship to pursue his PhD, but he's taken leave from that, deciding instead to lead MedChart. His pursuit of entrepreneurship means that he's led 3 companies, and as CEO, he's now got to the point that he's won top prizes for his entrepreneurship and the launch of his startup. He is a believer that there's a true demand for easy access to personal medical records, and his focus has been on technology that puts patients at the center, and he's going to share with us his thoughts on social license now.
Thank you. Thank you so much. So that was a very kind introduction, and I just want to start off with saying thank you to Tekna, because through our journey and creating MedChart, Tekna's played a role in that, in supporting us at the early stages of our company, and have allowed us to be as successful as we are today, having grown now to 2 offices, almost 20 employees. And if you haven't seen the Canadian Healthcare Technology magazine for November issue, we got the cover page around showing real evidence around our system being implemented in a hospital setting for almost a 2-year period, where this is being used today with patients, and actually is being piloted at UHN today as well. So with that, and the reason I want to qualify it is because the first thing is, when I describe what we do, a lot of people think that it can't be done, but it can, and we have the evidence to show that it can. And that is the concept of flipping the healthcare system on its head in terms of data ownership and data control, where right now under the current model, a lot of the data is entrusted to the physicians in the healthcare system in a way that they have a fiduciary responsibility to work with that data on your behalf in a responsible manner. But what if you were the owner of your data, and now you controlled where that goes, what it's used for, and who has access to it with complete transparency? That is your answer to how you can solve the problem of, now you are pulling together data from 5 sources with great technologies through patient portals and other solutions, but you've got the complete picture, but the people who can get value from it don't. Isn't that strange? So if you now are enabled to enact the ability to share that through explicit and informed patient consent, and a technology to connect that to the different data sources, that solves the problem. Because now you can just send your data to whoever needs it, and they have, under the law, the right mechanisms to be able to consume that, use it, analyze it, and you can literally do anything you want with your data.
I'm really happy I met you.
So our business and what we do is we've built a health data sharing platform. We're not trying to be a patient portal. We're not trying to be an interface or an interaction point. What we're trying to do is build tools on the back end that will work inside solutions like patient portals, like other applications that patients are going to be interacting with from all sorts of different sources, like AI applications and tools that enable those tools to leverage patient consent and also have access to a patient-owned clinical data repository that can be used to enable those tools and make them usable and actionable. And an example of where this brings value is if you think back just to the previous talk where the entire talk was a lot about training sets and large data sets and how do we build models out of these data sets. And then at the very end, there was one slide or a few slides around what does this tell us about one specific patient? Now that's the most important step because that's where you're going to make a difference in that person's life. And right now we can build a lot of models and we can work with Vector, we can work with ICES in order to develop these amazing models, but then when we go out to use them, there's going to be a whole bunch of sticky issues when you bring this into the real world, when it comes to data sharing agreements, when it comes to challenges around privacy and identity and consent that can all be solved if the patient just says, here, take it, use it, and here's my signed authorization that says, go run with it, which it sounds like you would do in a heartbeat tomorrow.
In a heartbeat. Mm-hmm.
So that is just an overview of what we do around making patient ownership of data a reality, giving them control for any purpose whatsoever that they would want, and also enabling the collection of the medical record from any healthcare facility in Canada. And our customers today are driven by who patients want to share their data with. And you know who our biggest customer segment is? Personal injury lawyers. Lawyers. Patients are already sharing tons of data with lawyers, a lot of data with lawyers. And this is an application of sharing information that is completely outside of the scope of what you would think of typically as someone working in the healthcare system. But I would argue there's a social license around how kosher it is to share that, to help them win a certain case, an injury, whatnot. Similarly, life insurance, well, they're the least trusted. Little do people know today that in the fine print, whenever they're doing an application, they're giving that life insurance company the right to approach their physicians and collect all their medical records. Keep that in a black box. No transparency to what's being collected or what's being used. In our system now, that's all above water. You actually walk away with a copy as a data owner, and you can share a copy, let's say, with your insurance company and audit their use and be fully aware and informed of what that's being used for. So I want to, when we're thinking about my perspective on health data and the social license related to AI, I want to step back from the population level and start to think about the individual level and with the power that that can bring. So what is social license? I did a quick Google search, and it came up as it's the ongoing acceptance of practices and procedures socially. So what does that mean? It seems sort of passive. It's sort of when you do something as an organization, it's sort of trial and error. You're checking, is this going to have a negative reaction by the public or in terms of perception or the people around us? And I want to, since this is the first time that we're talking about social license in the context of healthcare, I want to propose that there's an idea of doing a check around enabling that check for social license and figuring out whether or not the action that you're doing is something that would pass, let's say, a social license test. And in order to do that, I think there's three main pillars of how you can do that check and get the correct feedback that you need from your user base or your patients or your population that you're affecting in order to allow them to give you the appropriate feedback. And that's one around transparency of what you're doing. So in AI, this is particularly important because those who understand AI understand that we're applying these mathematical models to create inferences around the data, but for the general public, they think it's the Terminator. So it's, you need to be able to bridge that divide and give them that transparency around what the data is used for, what the AI is actually performing and doing. The second one is around control. So if someone doesn't like what you're doing, instead of letting it build to a point of explosion or, you know, a movement of people going against something that could have great benefit to the healthcare system, allow people to make decisions in real time around making changes to what they're comfortable and not comfortable with. So that way you can avoid these things altogether. And then also an understanding and an education piece to those individuals as to what it means, what you're doing, and also what control and anything that you're providing transparency on means, so that way they understand what they're actually doing. So, I mean, my stance is that when it comes to social license for AI, we need to think of providing people with the ability to accept some risk that may be outside of that or on the boundaries of that typical circle that you drew on what's legally acceptable versus what's socially acceptable, but also accept some of that reward. And I think the concept highlights a mismatch generally between what is written in the law and what is acceptable in, let's say, the court of public opinion. And this social license is very powerful. If we just use the example of the legalization of cannabis recently, that I would say it was a social license that was established in the 1960s. And it took 50 years to make it come to change law, but it shows that you know, we need to make an alignment between what we're doing within the healthcare system and what patients expect, and use different mechanisms and ways to get there faster, so we're not waiting 50 years before we can start to apply AI directly to real patient data and start to make an impact in patients' lives. So thank you so much.
Well, thank you, James. That's great. And I would like to also personally thank James. I mean, James works with hospitals, including UHN that you know, but for highlighting this sort of interesting use with personal injury lawyers and insurance, that for the patients he works with is what they want to do. It gives them control over their data in ways that they didn't have it in the past, and they receive direct benefits, so sort of pushing the boundaries there. Okay, so for the next section, what we're going to do is do some polling around fictitious examples, fictional examples related to social license. And I'm guessing that many people in the room, you know, your first reaction will be like, I don't know, I'd need to know more kind of thing, right? It depends. But what we're going to ask you to do is just sort of go with your gut on this. So this is Kahneman's System 1, thinking fast. Like, what's your first reaction? Are you oriented to say, probably within social license, I'd need to know more to confirm it? Or, wow, I'd be surprised if that's within social license. I'd need to really see a lot to be convinced. I also actually, forgive me for doing this now, I wanted to mention Michael Hillmer from the Ministry of Health and Long-Term Care was intended to be a member of this panel. As people may know, there was a major change in the structure of the ministry, and he's taken on some new responsibilities and was called into a full-day meeting, and for that reason couldn't participate. But he did want me to express his regrets. So next is going to be a poll, and I'll have to admit on this one too, I'm going to put it up. It's about something that's in the headlines right now. I want to make it clear I am not poking fun at this group. I know this group very well, and I can tell you this is a group committed to public engagement. So that's our first poll, but still we're going to see what you think about it. And it's not actually health AI. But the point is that how people see data use in one circumstance can affect their trust in other potential uses. Oh, but first we're going to find a little bit about you. Sorry. So of the choices below, we'd like to know which one of these categories is the primary hat you're going to be using when you respond to online polls. Clinician, researcher, clinician being defined as someone who makes decisions about individual care for individuals, whereas a policy or decision maker might be focused primarily on groups of people. A patient, we're using the CIHR definition here, which means it's inclusive, it's patients, it's caregivers, it's family members. You're thinking from the perspective of someone receiving care yourself or close to them, trainee, graduate student, none of the above. And there's going to be a second question about the second hat that you're wearing. And we'll share the report with this after the fact so people can see how the results break down. Noting this is not an REB-approved study. Okay, we're more or less stabilized. Some people still are, maybe they're wanting to boost up different categories. That's okay. It's coming from a good place. But mostly researchers, between researchers and clinicians, I'd say we're about 40%. And then we've clearly missed something when we've got a lot of none of the aboves. Okay, do you have a second role or perspective which you feel will influence your response? Okay, and there I would say nice to see people saying, patient, right? Whatever role we have, whatever work we have, all health is personal. Okay, not answering this won't prevent you from responding to the poll, so I'm going to switch to the first poll, and I think we've got 6 or so. And this is the one where I say right out of the headlines. Is it within social license for Statistic Canada to use data from banks to get a more complete picture of the financial well-being of Canadians, right? So Prime Minister now speaking about this, investigation by the Privacy Commissioner, Chief Statistician worried that this is putting practices that have been in place for years at tremendous risk, consultative organization, right? And in the room, most of us think this is okay, but you wouldn't get that from the headlines of the paper. Okay, first health AI question. Is it within social license for 3 hospitals to pool their patient-level data so that they can develop a more accurate A model to predict which patients are likely to have poor outcomes post-discharge? That might stay at 100%. However, this is not legally allowed. You can do it through an intermediary, like ICES, a prescribed entity, and of course you can have the individual patient data. The patients can bring in their charts or you can request the data. But if you actually wanted to do this as hospitals collaborating with each other, this is not legally allowed, hence the TASN frustration with their efforts to bring data together. Okay, is it within social license for a hospital to create a spin-off firm that uses AI applied to the hospital's medical images for early prediction of osteoporosis? So we're bringing in this private sector that Jennifer identified and that other studies have identified as well. This is sometimes what makes or breaks social license for some people. There's no independence, it's just your initial orientation towards this. It depends, yeah. But is your initial orientation to be like, I'd be really surprised if that's within social license, or yeah, I'd need to see the details, but I think it could be. Okay, so.
You can ask Marilyn for a comment on.
Would you like to comment throughout?
I just wasn't sure when I was allowed to speak.
Oh, you're allowed to speak. Everyone's allowed to speak anytime, but there will for sure be time, once we go through the polls as well.
There may be a reason for not giving me the microphone. So my initial reaction to that was yes. However, I would ask for a definition of what you mean by a spin-off firm and how is that connected to the medical people at the hospital. And the question before that, when people come in to predict their propensity for maybe early discharge or not a good discharge, what would knowing that information help the staff do differently, or would it do anything differently? So I think it's great to have the information, but there are only so many resources available to do the work. So how would that help? That was the part that I wasn't clear on. So
the activity, whether within or without or outside of social license, does the activity itself have value as part of the consideration? Okay. We'll move on to a few more. So here's one, a scenario. An AI firm works with record-level patient data to optimize patient flow at a hospital at no cost. They say these are free services we're providing to you, Hospital X. But what we want to be able to do is commercialize the technology, the models we develop working with your hospital's data. Is this within social license? I'll disclose here too that after dinner with the panelists, we went and I made some more scenarios to make sure that we didn't get everyone saying yes, yes, yes to everything. So it's actually good to see the mixed responses from the crowd. Okay, I think we got 2 more. Scenario, a pharmaceutical firm with a product line focused on HIV/AIDS wants to partner with a hospital system to apply AI to identify genetic biomarkers predicting responsiveness to treatments. Is this within social license? And clearly there are many factors behind this. We know this, but just testing your first blush response to get some thinking going. And then our final scenario, here comes the insurance company, but they have a focus on wellness. And they want to partner with a hospital to study the characteristics of people who recover most quickly and completely from major accidents. Is this within social license? Marilyn's, she was the one who suggested an insurance-related example. Okay, so with that, we've got 20 minutes, and we're going to turn it back to Q&A and dialogue with the panel members. And I think, following Marilyn's lead, starting maybe with the panelists, as you've heard each other speak, as you've seen the results to the polls, any first blush reactions before we take our first question?
I think it was interesting on your comment that it isn't just a static question, it's actually the dynamic aspect. So I found those last 2 cases quite interesting. So it was okay for pharma to find a biomarker, although we have no idea who's going to commercialize it or be at benefit once that biomarker was found, but it wasn't okay for the insurance company to find wellness. So it's interesting that it does require that next step. It's not just this answer the question, is it within social license, but sort of what happens next. And I think that was getting to your W's and your H, right? So what's actually going to happen after that step happens, that we find the biomarker, who's going to benefit,
what are we going to do with
what are we going to do with it?
So one of the things that really struck me was something that James said, which is social license passive? And I think in the definition, it's almost like a retrospective description. Is there social license? But could we imagine, and I think this is where we have an opportunity right now, we're starting to see it happen, where it's a much more active engagement, so a much more partnered approach to this. And Alison, I think you said something like this, so the stakeholders coming in and being part of, and you're hearing a lot of this about co-design, and this idea of ethical design is when you also bringing the end users in to be part of this. And I think we may be able to create conditions for social license by engaging in those types of activities. Now, this is where I think, adding on what James was talking about too, is that even at a population level, some of those issues related to ownership and engagement, those are also democratic values that we also care about too. But there may be some unique populations, subpopulations, for whom this is absolutely essential. So, for example, there may be groups or communities like Indigenous communities where it is only going to be, there's only going to be any movement in this area where there is active partnered work. So if you look at some of the differences in the survey data that I saw across the country, we cannot make a global comment actually about Canadians. You need to get finer into the details, and so there is going to be some additional work we need to do to understand for whom and who the who is that will be benefiting from this work from their perspective in order for us to be able to move forward. But I think it's an exciting area, and it's just ripe for opportunity for us to engage in a broader public conversation.
Hello? Yeah, I was actually surprised. The one that surprised me most was to give this AI company, who's external to the hospital, access to record level data to build a commercializable data set for free. That there was way too much. There were way too many yeses there that I would have expected it to swing the other way, just for many reasons around. The fact that it's record level data, so you're getting right into the weeds of the most sensitive information. That data, when training an AI, is being added to a training set that if you let that company walk away with it, that's permanently part of their database. If they ever have a breach or an issue with the way that they're storing or using that training set, you've just breached record level data. So there were some concerns there around that, and I'm not sure if it's a bias from the high level of researchers in the room. They're just like, yeah, let's let's just dig into everything. But I mean, I think that you could. There must be a desire to be able to do something like that, and you could do something like that with the appropriate social license in place, where going back to that transparency and control and making it completely above water with the patient, that you could probably accomplish doing that for your AI and your research. So that's just my comment.
I guess my comment at this point is this is a huge topic, and this isn't something that we're going to be able to solve in one session, and it may not be solved for years and years, because I think it's going to evolve as we go along. But I always look at any kind of decision or anything we're doing is what's in it for me, the old WIFM. And all of those questions, I go with the lens of what's in it for me. Now, there was something about compensation. If somebody wants to pay me to give my data to help with something, I might be interested. I don't know, nobody's ever asked me. But that's kind of an intriguing topic. But the other part of me says, let's just get on with it and start doing things and pick up the pieces.
So I'm so interested in some of the comments that are coming up here, and we've talked about the complexity and embracing complexity, and we've talked about how AI is such a broad topic, and you led with how much people don't necessarily understand the cloud or AI. And I'm reminded of a previous national public consultation that we did on the topic of xenotransplant, which was an incredibly complex topic, and it was only through citizen forums and engagement and education that we were able to ensure that people understood. So I think you're right. I think this is a start of a discussion. I think that we have a sophisticated country that could, with the appropriate knowledge, help us move this forward as a team, as a coalition, to try to understand some of these really important comments that are coming up. And I think there's real potential here in a collaborative, multidisciplinary way to do it.
So thanks for that, Heather. And I'll just add, if we don't want this to seem daunting, some of the comments are like, this is a starting point. Absolutely. So what does it mean? It probably means beginning with those projects that you think on the surface would have social license, but you don't actually start them till you check with people who would at least advise on the boundaries. And then recognizing that we as a collective are going to have to learn as more projects are done. I think it does mean not like giving some thought to it, not starting with something that you're thinking is on the boundary or maybe outside, because any new thing is tough enough already without it being that risky. So for sure, we want to take some comments from the floor, questions from the floor. So we'll open it up for that now. David? Yeah.
Yeah, the term license, I much prefer the term contract. And I have a feeling that the social side of the conversation is sort of talking about policy and alignment, but the technical side of the conversation is saying, hey, we can just build a technology that lets you have contractual control of every record on an individual patient basis. And that just opens up this beautiful data economy that could come to life around this. And so the license space is sort of like a contrast between oil rights assigned to individuals and government-controlled oil rights. That happened, of course, in Canada just after the 1900s. But I mean, the idea we had a system to control rights so that resources were mined and extracted and incentives were built was very powerful in that context. But in the data context, we haven't built that tool yet. And so the idea that we have to create these broad scopes of license concept instead of much more contractual. And I'm just worried that we haven't really pushed ourselves enough to build the technology to allow us to have a contractual approach.
Yeah. So what I would say from what I know of the field is that there's no forced choice there. That around the technology and the potential for a data as a contributor to the economy in the same way that the health system can be a driver of the economy, that absolutely that would be contract-based. I think the idea of social license, what it brings is that in addition to whatever contractual obligations you have, it's possible that somewhere along the way you've drifted into something that people, for example, perceive as a surveillance society. That when they find out about it, they'll say, wait a minute, I didn't agree to that. I'm sure that all your contracts are perfectly executed, but are you telling me this is my data and these people are using it? So another way to think about it, and you know, now looking to make reparations, is like the HeLa cells, Henrietta Lacks, that story of how one individual's biologic material was taken without her knowledge and turned actually into an industry, right? It's that sort of, in government we would call it the sniff test. That's the beauty of it. It's this sense of, you know, at some point you may cross a boundary. You want to know where that boundary is. That boundary will change over time. It's influenced by factors outside the space that you're working in, but you do want to know where that boundary is, particularly if you're starting in a new area, I would argue. You want to be firmly within it, working in partnership with other players. Other questions? Yeah, Ian? Yeah.
Do you mind if I just
sure.
give a quick response? So in my mind, I don't see any reason why we can't be doing that right now today. You know, I mean, we've been enabling that sort of functionality for patients to set those directives and have that control over the past 3 years. And at, which country did you mention where the researchers approach the patients directly?
Denmark.
In Denmark. You know, there's no reason that can't happen now with the laws that we have and the systems we have in place. It's just usually when researchers look at that, at utilizing those avenues, the procedures and the cost of the RAs and the amount of labor and the time delays are inhibitive of being able to actually do it. And that's where we can bring in technologies. We can bring in technologies around blockchain. I saw a few comments on that. That can enable this at scale and at a click of a button with full transparency. A great example of things in the healthcare system today that can benefit from it. So AI is something that's coming, but there's tons that are being of projects and opportunities that are being overlooked today because of issues with the amount of time to get a data sharing agreement. So we are doing a project through the Healthcare Technologies Fund that we have private oncology nurses doing telemedicine, work from home model, may not even be in the province. And typically that wouldn't be something that you would be able to connect to the healthcare data from a hospital for a patient that needs to use that telemedicine service. Put our system in place. Now, whenever those patients are calling that telemedicine nurse, they're giving a consent and the data is being transferred because the social license is there, but the laws necessarily haven't caught up in order to enable that system-wide, and you need to go patient by patient. So it lets you sort of get around these issues and do it now. You don't have to wait. You can literally do it now.
Okay, we had a question from Yin, and then Paul. Yeah.
So I had two questions. The first was thinking a little bit about some of the issues we have with informed consent, right, and truly having informed consent. Because I do think the technology could be there, right, with blockchain and other stuff. But do you really believe that it is feasible, right, to get to a point where everyone completely understands 100% of everything, you know, that's going to happen, right? And then they can say yes or no, you know, from that. That's my first question. The second is, you know, do you also think there's a social license for the providers as well, right? Because there's a lot of technologies that are exploiting, you know, the, you know, radiographic reads and deep learning and other stuff, that, you know, decades worth of radiographic reads, right, for these systems. And so is that something that we need to think about, or is it just built in everybody's contracts? So, you know, it's the hospital's data.
So yeah, the informed consent thing I think is a really big issue, and I don't know how Health Canada is going to move at the pace that all of this is moving. We have done studies on informed consent for patients undergoing life-saving treatments, and they don't actually fulfill the informed consent process. They feel they have no choice. They don't feel it's voluntary. They have cognitive issues. They can't really understand what we're saying. That's just an example, and it may be more of an informed trust than a true informed consent. I think one of the biggest challenges as we look at these data sets is because what we're doing with them, from genomics to metabolomics to radiomics to proteomics, when the patient originally consents, they may not have any true understanding of that fourth generation past what that data is for. I think that is a growing risk area for us. And again, I think that's why, you know, having this type of engagement with patients, partners, industry, and ethics is critical. So just, I share that concern.
And I'm just going to weigh in briefly too. My view is consented data will always be a subset of all the data, and we have to recognize who's not present in it. It doesn't mean it doesn't have value, but we have to know its limitations, particularly because some of our most vulnerable citizens are likely to be out of those consented data sets.
And just one thing I might add to that is that sometimes I think we think about informed consent in a too rigid way. So it's a moment as opposed to a process, an iterative, educative process. One of the difficulties I think we find, though, is that if we look at it from a research perspective or a clinical perspective, typically if somebody were to participate, for example, in a research study, they can say, and I'm going to withdraw my consent at some point. A lot of as soon as the data's out the gate and it's being married with other data, and then it's out. I mean, so I think what we may need to be thinking about are informed consent may be appropriate in certain settings in terms of providing warrant for data's use, but it's got to be much broader than that. So we do this already. We do this in public health all the time. That data is pooling regularly. No one's, like the consent is not the warrant on the basis of which I allow my data to be pooled with others. No, there are other factors that establish the legitimacy of the use of that data. So I think in this era, we need to think in a much more rich way, and I think part of it is all of us have been raised in a context of clinical and research activity that was consent-based in a particular model, and that model, we're starting to see the sort of erosion of its boundaries in a context of this context right now, which is very heterogeneous.
And because I had the benefit of speaking with him yesterday, I know part of what he's getting at, just to let people know, is, if you're going to have models that require labeled data and the clinicians are doing the labeling, well, they're contributing something to that too, right? Like, what about their license? If that turns into a commercial product that's based on their labor, interesting things to think about. Okay.
So my question relates specifically to aggregate data as opposed to individual data, because they're quite different in nature. And if we look at the first speaker, if we pay attention to some of the things that the first speaker had said in the previous session, he talked about the importance and quality of the data, the nature of the data that comes in. The best example was the age, and all of a sudden at age 100, the interventional data that's coming into the model becomes very, very differentially important than the interventional decisions made at 85. So that means certain jurisdictions, let's take Ontario, let's take Canada, certain jurisdictions and even certain hospital networks have access to different databases that they pretty much consider their own. Will be able to establish AI tools that are far more sophisticated and perhaps more able to service those patients in that jurisdiction in a differential manner than the database that will exist perhaps in Sioux Lookout or somewhere else. So is there social license for individual hospital networks to actually own the data at the prejudice of the health of patients depending on where they live in Ontario? As an example, but I think you could apply the same thing pretty much across the board.
Yes. I think yes would be the answer. So I think it was a great talk this morning, and obviously bias, which I think is what you're referring to, bias in the data coming in, and how the algorithms are trained on that data set, and if it is not properly inclusive, then obviously that bias will continue to exist. That already happens. We can look at large-scale clinical trials in cardiovascular medicine, and they're mostly 70% white men in their late 60s, and yet we apply that information across broad populations of individuals. So that bias already exists in medicine. I think we're finally recognizing it, and hopefully in truly looking at the training sets of data that we are using and recognizing the constraints that we can recognize. There'll obviously be other bias that we may not fully appreciate, but hopefully we can be more open to that, and I think Canada is uniquely positioned for that because of our multicultural nature.
Yeah, I think you drilled down even deeper specifically on a clinical trial, and I agree completely with those biases are there, but this set of data is very different now. This set of data is very broad demographic data. It's anything coming into the hospital system, so it's capturing so much more than, the white male 50 and so on. and that nature. And so my question that I'd like to see the panel tackle here specifically is, do regions who have stronger databases, more variable databases, become healthier as a result of having AI tools at their disposal that other regions will not have? Is there social license for that jurisdiction to own that data set, given that it was generated with public funds? That's the question at play.
I'll start with a bit of a response. I mean, I think overall we're moving towards an understanding that data are a public good, and that's a nice sort of tie back to the natural resources, start of social license. It's not there for any one group to preferentially exploit. There's no question, many have raised the possibility that health AI can grow inequities. And my personal disposition is that, and have the pleasure of working again with our leading researchers on topics like responsible AI, which include technology-based solutions to address that we have to make it our responsibility not to do that. You get into some interesting questions, though, right, about when you're pooling versus not pooling. Yin, in a talk he gave yesterday, mentioned, what is the right thing to do? Like, are you better to have a predictive model that's tailored to the population you actually serve? In which case we might encourage regional health authorities to, build up their own data capacity? Or is the better thing to invest, because all of this requires investment, in data that gets us to the biggest numbers possible so that we can get insights with the best accuracy, for subpopulations? I don't know the answer to that, but if part of what you're saying is there a risk that certain groups pull too far out front, let's put it that way, because being a leader is great, but if they pull so far out front that we've grown inequities, then I would say we'd fail. And one of the ways that we would know that is by involving patients and members of the public who would say, wait a minute, why are all these benefits being accrued just to, this small number of sites?
I would add to that. I think the truth is that if we're looking at lower socioeconomic status women and Indigenous peoples, we recognize that they're still not coming to the hospitals. So even if you're in a region that serves that general population, if they're still not coming to the hospital, you're still not getting data on those patients. So I still think that we have a long way to go to eliminate the potential bias.
I agree.
And just one final thought on that, just putting it in a global context. If you do a map of where all the AI investment is, it's in the high-income countries. It is so striking. And so, that's where the thinking is happening. That's academic as well as the startup side. And so if there's so much power that resides in high-income countries, then those are creating conditions that I start to worry about. What is this going to do in terms of global health inequities that already exist? And we can think of that on a smaller scale in a province or in a city as well. But that's just a...
Can I do variant? Yeah. Okay, so the one thing so the question was primarily around data quality. And the issue of one hospital site versus another getting better results with their AI because of higher data quality. I think right now there's a lot of work to be done, and there's a lot of change that's going to happen where the question based on current state is not like a completely irrelevant question, because the data needs to be pulled from primary care, from community care, from home care, from pharmacies. It needs to come in from all sources to get the whole picture to build a truly predictive model. And that's where, with the advances and changes and improvements in the data infrastructure, and also improvements in AI in terms of how sensitive it is to changes in the training set versus what it's trying to predict, because there's still a lot of advancements there to be had. We'll see more robust models that can do more with less, and also data continually getting better and better.
Marilyn, the last word.
Okay, and I just have two quick things, and Heather and Jennifer both actually brought it up, which it twigged to me is the data that's coming in from people that are middle class and above was one of my questions, and that was asked. But my last question that's been through my mind now, because I work on a project basis, and I love projects, and projects have owners, and projects have end of dates, and projects have plans. Who owns the project of social license? Who carries that ball every day when they get up and go into work and are going to put a stake in the ground and something on the table? It just isn't clear to me, and maybe Alison, it's you. I'm not sure. It needs an owner. Like somebody or a group of people need to carry this ball and get it across the finish line, and I'm just not sure who that is.
Yeah. Someone needs to own it. Maybe we'll all volunteer to do our part. So thank you so much, all panel members. This was a great discussion. And thank you for everyone for your online comments, too. They're fantastic. We'll close with that.
Thank you, Alison. So we're going for a break right now. So we have until 11:30. So please engage our speakers and our panelists. And thanks for your fantastic engagement this morning. 11:30.